We are pleased to introduce the topic of traumatic brain injury, or TBI, in the geriatric patient to the latest edition of Humans and Wins Neurological Surgery. This is a timely topic as older adults are seeing increasing rates of TBI, partially explained by the aging of the population. The authors of this chapter span the medical disciplines of psychology, psychiatry, neurology, and nursing. My name is Dr. Matt Peters, and I'm an assistant professor at the Johns Hopkins University School of Medicine, with joint appointments in the departments of psychiatry and neurology. My co-authors include Dr. Jennifer Albrecht from the University of Maryland School of Medicine and Ms. Michelle Diaz and Dr. Raquel Gardner, both from the University of California, San Francisco. In this presentation and the affiliated chapter, we start with the epidemiology of TBI in the geriatric patient. This is followed by a discussion of important clinical considerations in this same population, diagnosis and management, discharge planning, and outcomes. The epidemiology of geriatric TBI was nicely summarized in a 2018 review by Gardner et al., published in the Journal of Neurotrauma. Data from 2013 and 2014 suggests that up to 1 in 50 adults aged 75 or greater are evaluated, hospitalized, or die from a TBI on a yearly basis. The rates of TBI in older adults now outpaces all other age groups, including infants, and the numbers are rising. Falls are the leading cause of TBI in this population. Unfortunately, TBIs are less likely to be correctly diagnosed in the geriatric patient. This is at least partially due to the fact that most research to date has been conducted in younger adults, with applicability to older adults largely unknown. A 2019 systematic analysis published by the Global Burden of Diseases, Injuries, and Risk Factors Study 2016, Traumatic Brain Injury and Spinal Cord Injury Collaborators, in Lancet Neurology, showed that these high and rising rates of geriatric TBI are not solely a problem in the United States. As can be seen in this figure, older adults had the highest rates of mild as well as moderate to severe TBI globally. A key takeaway from the available literature is that geriatric TBI is different. Again, from the 2018 Gardner et al. Review from the Journal of Neurotrauma, the geriatric TBI population contains higher rates of women, falls, and subdural hematomas. The data suggests that mortality rates vary widely by institution, perhaps reflecting the lack of a standardized protocol for handling severe cases of TBI in the geriatric population. In regards to this, there has been progress in the development of trauma triage criteria, modified versions of the Glasgow Coma Scale, and EMS protocol guidelines for geriatric TBI. There are a number of important considerations to make when considering a geriatric patient who may have sustained a TBI. Here, we summarize the importance of pre-existing conditions, frailty, and polypharmacy. These are known to contribute to an increased risk of TBI, inaccurate diagnosis, delayed management, and worse outcomes. Presence of comorbid conditions is the norm and not the exception in geriatric TBI. The vast majority, over 99%, of older adults that sustain a TBI have at least one chronic condition. Some of the most common conditions include Alzheimer's disease and related dementias, depression, diabetes, cardiovascular disease, and pulmonary disease. Additionally, atrial fibrillation has been found in up to 29% of older adults presenting with TBI. It is important to remember that when a patient presents with a TBI, it is fairly easy to know if they have sustained a blunt force to the head. For example, a fall when walking, with the head striking the ground and leaving superficial bruising. Whether that blunt force has resulted in an underlying TBI is more difficult. In older adults, the presence of cognitive impairment or delirium can make this difficult to determine diagnosis even harder. Frailty is a growing concept both within the TBI literature and in the geriatric literature more broadly. In geriatric TBI, frailty has been determined to be a better predictor of outcome than age alone. There are a number of frailty indexes that have gained momentum with this recognition. The trauma-specific frailty index has been shown to predict short-term outcomes in geriatric trauma more broadly, and the Groninger Frailty Indicator holds promise in the prediction of long-term outcomes from geriatric mild TBI specifically. Frailty indexes include key components like mobility, nutrition, disability and daily activities, and comorbidity, as well as vision, hearing, cognition, and psychosocial awareness. We will likely see continued expansion of the literature on frailty and geriatric TBI in the coming years. Combating polypharmacy has been a focus of geriatric medicine for some time, and the Beers criteria are taught in medical schools throughout the United States. Polypharmacy is common in those with TBI. Not only does polypharmacy indicate medications that may increase risk of falls, but it also indicates the presence of chronic conditions known to increase frailty, morbidity, and mortality. Similar to all conditions in the geriatric population, the reduction of medications must be weighed against the necessity of such medications. With this in mind, a consult from geriatric medicine or transition of the patient from an adult primary care physician to a geriatrician may be beneficial. As mentioned earlier, confirmation of a TBI is much more than confirming trauma to the head. A diagnosis of TBI today rests largely on the clinical assessment and neuroimaging, both of which may be misleading in a geriatric patient. In this section, we discuss some of the pitfalls of established clinical assessments and neuroimaging in the geriatric population, as well as emerging blood-based biomarkers. The Glasgow Coma Scale, or GCS, is a widely used scale for determining TBI severity, both in the field by EMS and within the emergency department. The GCS is known to lack sensitivity in geriatric TBI, meaning that false negatives are a major issue. A few patient-level elements that are known to influence the accuracy of the GCS are the same as the elements that make geriatric TBI different, including pre-existing cognitive impairment, comorbidity, polypharmacy, and age-related cerebral atrophy. Neuroimaging can play an important role in geriatric TBI, especially considering that increased room in the intracranial vault from pre-existing atrophy may allow for the accumulation of blood without obvious clinical manifestations. In the geriatric population, non-contrast CT scans have been shown to detect evidence of intracranial TBI pathology in 11 to 21% of individuals that otherwise would have been classified as having a mild TBI. Just as important, 57% of older adults with a positive head CT present with a completely normal GCS of 15. Many trauma guidelines take into consideration age as a factor for determining whether someone should be scanned following blunt head trauma. The American College of Emergency Physicians recommends scanning of all individuals over 60 years of age who present with loss of consciousness or post-traumatic amnesia following head trauma. Furthermore, they recommend non-contrast head CT in anyone with blunt head trauma 65 years or older, regardless of clinical presentation. Blood-based biomarkers are incredibly enticing for TBI diagnosis given their potential to be relatively inexpensive and easy to collect. There was a lot of excitement when the FDA approved plasma, GFAP, and UCHL1 to rule out acute intracranial trauma without the need for CT. Unfortunately, these two biomarkers, as well as another commonly discussed in the TBI literature, S100B, do not perform well in older adults. Another assay, also used in neurodegenerative disorders, hyperphosphorylated tau, shows potential promise to detect CT abnormalities in older adults with TBI, but more research is needed. Geriatric TBI management shares many features of management of TBI in younger persons. However, in this section, we highlight some special considerations, including pre-existing anticoagulation, hemodynamic targets and monitoring, operative interventions, seizure prophylaxis, and palliative care interventions. Comorbid conditions leading to anticoagulant use are common in geriatric TBI. It is essential to recognize the presence of pre-existing anticoagulation, which may lead to intracranial bleeding and worse initial TBI severity. Early reversal for those on warfarin with prothrombin complex is recommended. For those on other antiplatelet agents, there is conflicting evidence of whether this has an impact on initial injury severity. Therefore, treatment with platelet transfusion is only recommended if the patient is to undergo a neurosurgical procedure. There is a particularly severe lack of evidence-based guidelines for blood pressure targets, the role of intracranial pressure monitoring, and cerebral perfusion targets in geriatric TBI. The Brain Trauma Foundation has made recommendations on systolic blood pressure monitoring with a goal of over 100 millimeters of mercury in those 50 to 69 years of age and over 120 millimeters of mercury in those older than 70 years. This is one area where research is needed to determine optimal targets in geriatric TBI. There have been limited focus studies on the use of operative interventions in geriatric TBI. The evidence is conflicting on whether neurosurgical procedures, including craniotomies and ICP monitoring, reduce morbidity or mortality in the geriatric population. When there is evidence of significant mass effect from subdural hemorrhage on imaging, neurosurgical evacuation is indicated. Similar to younger individuals, the most commonly recommended anti-seizure medication for those considered at risk, especially those with more severe TBI, is Keppra. Keppra, in general, is a better choice due to linear kinetics, fewer drug-drug interactions, and lack of negative effect on balance. As mentioned earlier, given the role frailty and polypharmacy play in geriatric TBI, this favorable side effect profile is worth considering. There are cases of geriatric TBI that result in catastrophic or life-changing injuries. Neurotrauma clinicians, especially those in neurocritical care units, play an important role in making the initial decision to consult palliative care or end-of-life hospice care. Early discussions with the family to discuss goals of care and advanced care planning are encouraged. Always check to see if an advance directive or similar is available. Palliative care interventions can be beneficial to even those geriatric TBI patients that are expected to survive, as these injuries can be life-altering. Evidence supports the role of palliative care interventions in decreasing ICU length of stay, ICU admissions, and decreased healthcare utilization and spending near end of life. Most cases of geriatric TBI will eventually be discharged to home. In this section, we review important discharge considerations, rehabilitation, and prevention of re-injury. As with many incident conditions, TBI education for the patient and caregivers can play a dramatic role in helping with the transition out of the hospital. A medication reconciliation is essential, no matter how time-consuming it may be. At times, patients are being discharged home with a spouse who is themselves cognitively impaired or inexperienced in caregiving. Ensure that the appropriate medications are to be administered, and minimizing polypharmacy are essential. Additionally, there are resources, sometimes from the hospital and sometimes from the local community, for home safety evaluations and social support. There may be a new onset functional impairment in the injured geriatric TBI patient. Although some of this can be anticipated prior to discharge, ongoing monitoring of home functioning and utilizing social support to ensure the patient and caregiver are getting by is important. As some of these patients must go home with medical equipment such as hospital beds or neck braces, home services may be required. For some, the transition out of the hospital will include a rehabilitation plan, which we highlight on the next slide. Although follow-up with a geriatric TBI expert will prove difficult in many areas, ensuring that the best possible follow-up care is arranged is essential. This may require a direct communication between the inpatient team and the outpatient team. For many patients with geriatric TBI, some level of rehabilitation may be indicated. This may be inpatient rehabilitation, outpatient rehabilitation, or services delivered within the home. Physical medicine and rehabilitation specialists, occupational therapists, and physical therapists can be consulted during the hospitalization to help ensure needed services are arranged. Additionally, speech-language pathologists often play a central role in those requiring cognitive rehabilitation. With the appropriate services, many patients are eventually able to return home. Although the time to recover may be longer than in younger patients, the net functional gain can be similar. A final element of discharge planning relates to taking measures to minimize the risk of re-injury. An essential part of this is fall risk assessment and prevention. This may involve consultation with a physical therapist and may even require a home assessment. Even if only a one-time visit, these home assessments can go a long way in mitigating risk. Additionally, group and home-based exercise to strengthen muscles and improve balance can be helpful. The final section of our chapter covers outcomes in geriatric TBI. On the whole, mortality is higher following geriatric TBI than in younger adults, and this is at least in part due to higher burden of pre-existing conditions. Unfortunately, the existing prognostic models for outcomes after TBI do not perform well in the geriatric population. Similar to the GCS, the Glasgow Outcome Scale and Glasgow Outcome Scale Extended, which are widely used to examine TBI outcomes, are not validated in the geriatric population, nor do they perform well when pre-existing disabilities exist. Lastly, it is important to remember that although older adults may achieve the same level of recovery as younger patients, it may take longer. This is important as decisions to withdraw care may need to be deferred to greater than 72 hours post-injury. Looking at neurobehavioral outcomes, a few conditions are worth noting. Older patients are at higher risk of developing new-onset seizure disorders than younger patients. The presentation of seizures may be delayed and well into the recovery process. As mentioned above, Keppra is often used given its side effect and interaction profile, with lamotrigine having good evidence for use as well. Geriatric TBI, similar to TBI in younger adults, can result in new-onset psychiatric symptoms or may impact the presentation of existing psychiatric syndromes. Depression and anxiety are both common, and the risk is highest during the first 5 to 6 months post-TBI. Additionally, it is important to assess for cognitive impairment in those with geriatric TBI. Although it can at times be difficult to know whether the cognitive impairment was present pre-morbidly or is new onset, either way, these symptoms need to be noted and monitored, as they may impact the ability to participate in rehabilitation. There is some evidence that subjective memory is particularly vulnerable to geriatric TBI. The complex link between geriatric TBI, as well as TBI at younger ages, and neurodegeneration is an active area of research. The evidence has become more consistent that TBI, especially geriatric TBI, is linked with an increased risk of all-cause dementia. Additionally, there has been a consistent link between TBI and Parkinson's disease. We summarize our chapter on geriatric TBI with a few key takeaways. In geriatric TBI, pre-injury health and functional status strongly impact prognosis. Diagnosis is complicated by pre-existing medical and neurological conditions, as well as functional and cognitive disabilities. Recovery trajectories are slower than in younger patients, but many older adults can recover well after TBI. Frontline providers should serve as aggressive advocates for geriatric TBI patients. There's a critical need for improved diagnostic tools, prognostic tools, and treatments for this population. Thank you for the opportunity to tell you about this important population.